afternoon, everyone. Thanks so much for joining today's webinar. My name is Kate Morales. I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep United. We are excited to present today's session on community-based services to improve hepatitis B testing and linkage to care among hard-to-reach populations. Today's presentations will include findings from 3 hepatitis B testing and linkage to care programs that were supported by the CDC between 2014 and 2017. And the programs that were featured is also available. They were also featured in the May 2018 MMWR, which you can download in the handout section of your control panel. Today's webinar is being presented by Hep United, which is a national coalition of over 40 national and local organizations working across 19 states to increase hepatitis B awareness, testing, vaccination, and linkage to care among high-risk communities. Before we get started, I'd like to review a few housekeeping items and let you know how you can participate in today's webinar. Attendees are in listen-only mode. You are muted during the presentation. There is a phone-in option, and the call-in numbers are shown on your screen if you are not able to access the computer audio. And then finally, you may submit questions in writing during the presentations by typing them in the question box on your control panel. We'll be reviewing them as they come in, and then we'll hold them for a question and answer session after all of the presentations. And today's webinar is being recorded, so you will receive an email with a link to view a recording of today's presentation after the webinar. And I'm going to go ahead and introduce all of our speakers for today. We have a really exciting lineup of excellent speakers. Dr. Paul Weidel is joining us today. He's the Acting Director of the Division of Viral Hepatitis at the CDC. And Dr. Weidel will be providing updates from the division. And then we'll jump into our presentations with Dr. Aaron Harris. He's a medical epidemiologist with the Division of Viral Hepatitis of the CDC, followed by our 3 programs around the country. Dr. Karen Kim is the Director for Center for Asian Health Equity. She's also with the Board President of the Asian Health Coalition in Chicago, Illinois. And then Duke Litran is the COE Coordinator for the Office of Community Outreach and Engagement at UC Davis Comprehensive Cancer Center. We'll be talking about his program in Sacramento, California. And then finally, we'll wrap up with Livingston, New Jersey, and also the New York City program presented by Dr. Lee Wong, who's the Medical Director for the Center for Asian Health at St. Barnabas Medical Center in New Jersey. All right, well, I'm going to go ahead before we jump into presentations, and welcome Dr. Paul Weidel from the CDC, and Dr. Weidel will be sharing updates from the division.
Hello, thanks for having me. Really looking forward to the presentations today. There's a terrific amount of work that was done, led by Aaron Harris in our division, but then with all the people from the field who will be presenting as well. I'll just give a few updates from the Division of Viral Hepatitis. I've been the acting director for the Division of Viral Hepatitis since April of this year, so going on, starting into my 7th month soon. It's been a very interesting time, and it's been a pleasure and an honor to work with people like yourselves and then other people around the country and here at the division. Just to give a brief overview, our two largest external funding mechanisms are our COAG, the Improving Hepatitis B and C Care Cascades, focus on increased testing and diagnosis. That's funding we also call it 1702, that goes to 46 states and 4 jurisdictions, and that is in the second. We're entering the 3rd year of a 4-year COAG, and the other is strengthening surveillance in jurisdictions with high incidence of hepatitis C virus and hepatitis B virus infection. That's also referred to as 1703, and that's a surveillance in 14 jurisdictions that were selected for that COAG. Some of the new activities that we're going to be having this year to support these things, and some new things. One is we were able to provide funding to NASDAD to provide comprehensive technical assistance for state hepatitis prevention and surveillance programs. So we'll be working with them to be able to provide the state additional technical assistance. Probably the most exciting thing that we're going to be doing this year, and it's in the final stage of work, figuring out, finalizing the work plan, but we're funding the Association of State and Territorial Health Officers to help develop plans to support planning, for national and state viral hepatitis elimination programs. That's for both viral hepatitis B and hepatitis C, to work with the states to develop elimination programs. So we'll be working with ASTO to work with the states to develop, for the states that have already developed plans or in the process, to help them further their development, for states that haven't quite started yet to help jumpstart that process. We're very excited about doing that. We'll also be able to develop more epidemiologic profiles for viral hepatitis, for viral hepatitis B and hepatitis C in another 8 jurisdictions. I think to date we've done 22 states in the country over the last number of years, and we had funding to be able to do 8 more this year, and I think the states find those very helpful for their planning and such. And then last thing, that we're going to have an emphasis on working with syringe service programs and harm reduction programs to provide support and guidance for those. In particular, we have a COAG where we're trying to work with external partners to establish performance standards for syringe service programs to try to determine what would be good practices with different size SSPs. Of course, some are very big and can do a lot of things, and some are smaller, to try to develop guidance for how they should be able to work. So that's some of the new stuff that'll be starting this year. It's all kind of rolling out now, and we look forward to work with our external partners on these things. So with that, I will stop, Kate, unless there's something else you want me to address.
Oh, that's wonderful news. Thank you so much for sharing these updates. Sounds like there's going to be a lot of exciting programs going on around the states this coming year. And if I just wanted to note, if anyone has questions, Dr. Weil will be on the line and able to take questions at the end of the session. Okay. So we're going to go ahead and move on to Dr. Aaron Harris' presentation from the CDC.
Good afternoon, everybody. Today I'm going to talk about the community-based services to improve hepatitis B testing and linkage to care among hard-to-reach populations. And I feel very privileged to be giving an overview over this program, because I was lucky to work with such great collaborators from Chicago, New Jersey, New York, and Sacramento, and it's good to have everybody on the line with me. Next slide, please. This map shows in darker shades of red where the highest prevalence of hepatitis B is worldwide. And you can see that the majority of the burden is in sub-Saharan Africa and in East and Southeast Asia, or the Western Pacific region. And 80% of the world population resides in these intermediate to high hepatitis B endemic countries. Next slide, please. In the United States, there's about 1 million people living with chronic hepatitis B infection. And of those 1 million, 65% are unaware of their infection status. About 70% of the hepatitis B cases are among foreign-born persons. There are about 1 million immigrants who enter the U.S. each year, and more than 60% are from intermediate or high hepatitis B endemic countries. The countries with the most number of imported cases include China, Philippines, Vietnam, Korea, and India. This leads to about 54,000 chronic, can you hit the slide one more time? I think the table needs to show. Yep, there we go. This leads to 54,000 chronic hepatitis B cases imported annually, compared to about 4,000 U.S. acquired cases. Although in the current opioid epidemic, we are seeing an uptick in cases in the U.S. Furthermore, the mortality associated with imported cases is substantially higher among the foreign-born population than the U.S. acquired cases. Next slide, please. The graph here shows an overview of the hepatitis B care cascade nationwide. Although this is from 2011, we need to update it. But what you can see here is that of the 1 to 2 million people infected, only 30% are aware of their infection, 15% are entering into care, and only about 10 to 15% of eligible patients, of treatment-eligible patients, are receiving treatment. So there's lots of gaps in the care cascade that we are trying to address through our work at CDC. Next slide, please. So the purpose of the hepatitis B testing and care program is to improve the capacity of healthcare providers and other stakeholders to serve populations of persons born in countries with intermediate to high hepatitis B prevalence. And the goals were to increase testing of the high-risk population, the non-US born persons, increase vaccination of susceptible persons, and increase linkage to ongoing high-quality hepatitis B-directed care for persons identified with chronic hepatitis B infection. Next slide. Each site implemented the following interventions through partnerships with public health, community organizations, medical care clinics, and specialty practices. They implemented recruitment of foreign-born persons and conducted screening with hepatitis B surface antigen, hepatitis B core antibody, and hepatitis B surface antibodies. Care was coordinated through community outreach to improve the capacity to identify persons who have previously been tested surface antigen positive who were not receiving care, and they offered services such as patient navigation to ensure medical evaluations by healthcare providers participating in these partnerships were done, and increased community and health professional hepatitis B awareness. In addition, sites offered training to staff to enhance screening, monitoring, management, and referral practices consistent with CDC, USPSTF, and AASLD clinical management recommendations. Next slide. So the results of our program are shown here in this graph, and we identified 757 persons with chronic hepatitis B infection. Of those, 85% were linked to care, 78% were engaged in hepatitis B directed care, and 57% were retained in care. The number is probably much higher for retained in care, but at the time the program ended, it was 57%. And I'm sure that the programs are continuing to see these patients, so I'm sure that number is much higher. And 18% were prescribed antiviral medication. And just keep in mind that it's thought that only about 20 to a maximum of 40% of people are eligible to receive medication. So 18% receiving medication is terrific. Next slide. Getting into some of the nitty-gritty of the data, the unadjusted odds ratios for selected characteristics in achieving linkage to care or antiviral prescription among persons with chronic infection are shown in this table. Persons older than 50 years or whom had no health insurance were less likely to be linked to care. And persons who were of male sex, older than 50, had liver cirrhosis or hepatocellular carcinoma were more likely to be prescribed an antiviral medication. Next slide. The programs also implemented testing and vaccination of household or sexual contacts of persons with chronic infection. 14% of household contacts tested positive to surface antigen, and 30% had evidence of prior infection. So actually 44% either were infected or had evidence of prior infection. That's a very high burden in the household contacts. And of the 50 household contacts who tested negative to all three seromarkers, 74% received the first hepatitis B vaccination dose, and 50% completed the full 3-dose series. Next slide. Best practice implementation strategies for hepatitis B testing and linkage to care are summarized here. Educational curricula, including education of patients and providers, was important. Training protocols that can operationalize evidence-based practice into clinical workflows. Patient navigation services were critical to help foreign-born patients access and stay in care. Community outreach was important to recruit hard-to-reach populations to access care. Community screening events, especially those that included other general health concerns such as high blood pressure, diabetes, also helped testing. One site used the hepatitis B testing voucher coupon so that individuals could go get confidential testing when it was convenient for them. Further clinical decision support tools were used in the electronic medical record to flag individuals who are eligible for testing and also prompt providers to follow hepatitis B directed care recommendations. Next slide. In conclusion, hepatitis B testing and linkage to care can be achieved among hard-to-reach populations through partnerships with community organizations, health centers, and public health departments. Household and sexual contacts of hepatitis B surface antigen positive persons should be tested and linked to care or vaccinated. And patient navigators were critical for sustained linkage to care. Next slide. This slide just acknowledges Dr. Paul Weidel, Dr. Noel Nelson, and the 3 sites participating in this program. And I look forward to hearing from each of their sites. Thank you.
Thank you so much. And our next presenter is Dr. Karen Kim, who'll be talking about their work in Chicago.
Yeah, thank you. Why don't we advance the slide, please? So this is a program that was done at the Asian Health Coalition, which is a community partner for our Center for Asian Health Equity. And this is some of the team that was involved in this particular program. We also have a clinical advisory board and have worked across many community-based and provider partners. Next slide. So just by way of the Asian American demographics in Illinois, since we're talking about Chicago, we have about the 6th largest Asian American population. I think it's important that 80% of our population speak other than English, with 65% being foreign born. And as Erin just mentioned, sort of the cases of imported hepatitis are really high. And the poverty rate for Asians in Chicago are about 12%, whereas our state poverty rate is about 8.9%. Next slide. I think it's also important to know that less than 1 in 5 uninsured Asians are actually receiving care at community health centers. About 1.4% of those that are eligible are actually receiving care at community health centers. So I think this is largely due to the lack of culturally competent available health delivery services in Illinois, and so our populations continue to be displaced. And so I think the role of community-based organizations that probably see about 40% of our Asian population in Chicago really play a critical role to mitigate the infrastructure gaps through health promotion and prevention programs. And so we really want to talk about that program today. Next slide. So in 2005, we established the Hepatitis Education and Prevention Program in Chicago. This is really a multi-level intervention to address really the glaring gaps in hepatitis B education, screening, and vaccination rates among Asian Americans, and more recently, which include also African immigrants. And this uses a sociological, ecological framework to address individual, community, organization, and policy level changes. And we work very closely with our community-based organizations using a community health worker model. And this program has been funded by the CDC since about 2008. Next slide, please. And this is just an example of some of our accomplishments from 2006 to 2011. I wanted to show this because we screened over 17,000 people and referred to immunization, large cohorts of Asian community members. But really, despite this really enormous success, we have had a real failure in our ability to have adequate linkage to care, which is why the most recent programs with the CDC have been really helpful in us understanding interventions to link community-based screening into care. And to do this, next slide, we've had several community clinical partners. We have one site which we partnered with, which was a hospital-affiliated refugee health center, and we also worked with an FQHC network with 15 community, school, and behavioral health centers. At one of our sites, we're going to talk about the Hepatitis Patient Navigator as an intervention that has really helped shape our ability to link patients to care. And so one site had one navigator, another site had a team of 3, and both of these sites are located in the city. Next slide. We also have, as I mentioned, really a number of community partners, and without that, we really wouldn't be able to do this work. We've worked with over 10 community-based organizations that serve both Asian, ethnic-specific, and African immigrant communities. That has worked well because of the trust that's established with the communities, and they can provide ability for us to provide culturally and linguistically appropriate education and outreach. And I will talk about how these community partners worked with our Navigator to create a really interesting linking system. Next slide. So basically what we had prior to this particular, hit it again. These are just a list of some of our community-based organizations. Next slide. So really, this is the intervention we created. We know that in the blue circled, our community-based organizations have really big access to our vulnerable populations. They have bilingual community health workers who really are outstanding in delivering education and screening actually to the population. On the yellow side, we have clinics that may not have as much ability to reach into the community to help with screening and referral practices. And what we have in the middle is we created a community health worker hepatitis patient navigator relationship where we had reciprocal site training. Our community health workers went into the hospital health system. The hospital health system folks went into the community. We also did cultural competency training. We really created an interesting linkage handoff from community health workers to the patient navigators. Next slide. And just in terms of a little bit more about this linkage, so our hepatitis navigators were assigned to each of the hospital locations, and they were really responsible for the clinical component of notifying individuals, making sure that those who were susceptible received vaccine, and helping with case management, including navigation across the healthcare system. While our community health workers were really important in providing relevant health education, notifying our navigators of the screening results, and then helping create that link between the community and the health system to ensure that patients were able to make their appointment and keep their scheduled appointments. Next slide. A little bit more about our patient navigator. Oh, hit one more slide. So other things that our patient navigators did is they really helped the hospital system identify potential high-risk populations and flag them for screening. And as Erin mentioned, these are the ways that we screened individuals. But basically, we really they worked very closely with the system to make sure that there were completion of follow-up, that there were referrals to specialty care when they needed it, and to really alleviate any potential challenges for patients getting through the system. They also were really helpful in provider reminders. Next slide. So a little bit about the organizational sort of algorithm for how our program worked. You can see that there was consumer education and outreach. You can hit the next slide. And client recruitment and testing, which really was overseen by the community health workers. And when we found those individuals that were screened positive or that needed immunization, it was really a nice handoff to our patient navigator, who then helped with case management and working with specialty across the spectrum. Next slide, please. And this shows data from the hepatitis B care continuum from 2011, which really shows a large drop between the number of those who have infection and to the number who are aware of their infection and then eligible for treatment. Next slide. And you can see that this is an example of one of our hospital sites that had those that were tested positive in their care continuum. And you can see that we had almost 96, 97% of those individuals linked to care, which is in stark contrast to what we used to have before we developed the navigation system, where we had less than 5% people actually linked to care. So you feel like this is a really interesting model. Next slide. And in terms of program successes, we've done a lot with provider and staff education, including biannual education, and we discussed current guidelines and treatment modalities. We also wanted to make sure that we included frontline staff in the educational program. Next slide. And because providers really were getting fatigued by EMR prompts that we had put in, we really wanted to start doing recognition, quarterly newsletters looking at clinics that had done really great job in screening. And this really, we realized, was helpful in providers not ignoring our pop-ups that reminded people who were at risk that needed to be screened. Next slide. We also were involved in modifying our electronic medical records, where we wanted to start collecting country of birth to identify those that potentially needed to be screened. And our navigators helped enable pop-ups that flagged those individuals who needed to be screened, so physicians had an easier time identifying patients that they needed to think about. We also created an Asian Health Coalition Hepatitis B panel to make it one-click ordering that made it much easier for providers not to have to think about what they needed to do. Next slide. So in terms of some of the key lessons, we realized that small changes, first of all, that education is critical, that having set orders really makes a huge difference, and that patient navigation was really the key to success in linking our community with our clinic. And actually, we published a paper showing that community-based screening was equivalent to clinic-based screening in terms of linkage to care based on this model. Next slide shows we created a hepatitis navigator manual because we really want others to be able to learn from this process. And so I think Hep B United, and I'm sure we can get this manual into people's hands if you want that. And finally, my last slide, can you forward? Yeah. So certainly we know that this patient navigator community health worker handoff is a program that really works. And particularly among vulnerable populations, I'm excited to hear that Dr. Weidel is doing a lot around statewide programs to eradicate, but I think it's really important to make sure that we maintain ability of access for our vulnerable populations, which may not make up a large population of our state. We've also shown that community-based screening is really as effective in linking patients to care as clinic-based screening, and so I really suggest that you look into this model. Thank you.
Great. Thank you so much. Yes, and we will definitely be able to share the manual with our partners, and I can include that in the follow-up. All right, and then we're going to go across the country to Sacramento and hear from Duke Latran.
Hi, thank you for having me today. And so I'm going to speak to the Sacramento Collaborative to Advance Testing and Care of Hepatitis B, which is our Scratch B program. Next slide, please. And so I'll speak to the scope of hepatitis B in Sacramento, our in-reach arm, and then our outreach arm, and the impact that we've made. Next slide. And so, demographics of Sacramento. Our county has a 1.46 million total population with a 2.1 million metro, and we have about a 15.2% Asian population. And from the 2010 census, we're the 5th highest percent by API in the metropolitan area. And you can see that we're part of the Central Valley, and we're not necessarily in the Bay Area, which is more tech, and where our focus is agriculture, and so it's a very different geographical location. Next slide, please. This is a scheme showing our hepatitis B screening, and so on the right side is our in-reach, and we have our UC Davis health system and individuals who go through our hospital, our EMR. They would be tested to identify if they're Asian American, and if they're positive or not, they would be referred to our PCP and then to a hepatitis B clinic. And if they didn't have one, then they would ultimately be referred to the Sacramento County Health Department. And along with our community screenings, where we actually went out into the community, we went to local community faith-based locations such as churches, temples, community centers. We tested the individuals and provided free screenings, which required advertising and making it known and reaching out to our local CBOs. If the individuals were positive, we would refer them to our student clinic. There was a clinical trials that would enroll at the time, and then also we'd refer them directly to their own PCP. And if they were uninsured or whatever, we'd also refer them to our Sacramento Health Department. Next slide, please. And so for our in-reach linkage to care, this is a little bit background. I was the coordinator on the outreach arm, and our analogous case manager was Ann Sanchez, who I worked very closely to get the data in. She would look at all the 2-year retrospective and prospective quarterly reports of all the service antigen tests, and data was collected for their place of birth. She would review all the service antigen and see if it's positive, new versus prior diagnosis. And then she would also coordinate their care, which would require her to call the patient or make sure, and she was essentially the patient navigator for our project. And so for the UC Davis Hepatitis B Clinic, which was led by our PI, Dr. Christopher Bolus, and also Dr. Eric Chack, they had a case manager who worked within the clinic, and a pharmacist who also helped coordinate care. Next slide, please. And so recently, we also implemented this electronic medical alert to see if it would increase chronic hepatitis B screening, which is now a published paper. Next slide, please. And this credit goes to Dr. Eric Chack, who led this project. And what they did was implemented a novel algorithm to identify at-risk Asian American and Native Hawaiian Pacific Islanders who are not screened yet. And this contrasts with hepatitis C, which is easier, which you can just filter by birth. And some of the exclusion criteria includes, if the patient had a prior surface antigen, if they already had a hepatitis B diagnosis. Unfortunately, CMS did not cover the surface antigen at the time study, so they had to exclude that. And on the lower right there, you can see what the health maintenance looks like. And there's a little pop-up there that tells the provider, the PCP, that the patient needs to be screened. So next slide, please. And so what they found was that it was statistically significant. The alert more than doubled the chronic hepatitis B screening, though the effect itself was small. So it was an increase from 3.2 to 8%, which is still a small amount. But reasons that is why is perhaps the alert itself is passively in the chart, and the patient did not present to their PC during that time of the study, so the alert wouldn't be seen. And so what we found was the EMR did not increase the surface antigen positive test, which is the individuals we ultimately want to reach, but it did increase screening. So what we can prove is we want to add a patient navigator, inform patients and their PCP through other methods, electronic message, implement perhaps an opt-out CHB screening program. And since the September 9th, Medi-Cal patients have also had the alert activated. Next slide, please. And so a summary of our in-reach, a truce of interventions do work, but, we did get a little bit of pushback from the PCP. The EMR alerts, that also works, but, several things still remain that we need to address. Multiple partners requires implementing, a system-wide intervention. We have to work with the PCP, the IT, the insurers, the patients, and there's also, competing interests as well. And so, and also, the IT has multiple tasks that they have to do, and we have to wait in line as well too. Future plans, we plan to continue to expand the EMR alert and perhaps also trial pre-visit planners. Next slide. Next slide, and you can go ahead and click all through. And so now this talks about our community outreach, where we went into the community. We built relationships with our community-based organizations, met with the gatekeepers, went out to promote. We went ahead and trained our students and CBOs on the process and procedures. And then throughout the whole, the project period, we went and to the actual venues to go ahead and advertise. And the day of, we brought a mobile Hep B unit, which consisted of a nurse who would be able to draw the blood, and then also translators, and we'd be able to transport the blood back to our hospital as well. And so then the major part was doing the follow-up and linking to care, and we would coordinate that and schedule a track. And eventually this builds a lasting infrastructure within our community. So next slide, please. And so, we've had many past projects working with the community, back from 2007 all the way up to 2018, which ultimately led to our ScratchB project, which is one site of our MMWR. And so these are just past things that we worked on. Next slide, please. And so how we outreach to the community, we had social media, we had calendar events posted on our UC Davis website, newspaper, radio, flyering, and listservs. And listservs include different Asian-focused organizations that they interact with, such as Capital. And social media perhaps didn't really work with the community that we're trying to connect with the underserved Asian American population. But what really helped was the ethnic newspaper. And if anyone's familiar with the newspapers in the Bay Area or Sacramento, we have like Bao Tang Mall, Bao Lang, and Bao Haivan. And what really was helpful was that the different community-based organizations, whether they were like the radio or the newspaper, they were really receptive to helping us. They would give us discounts, and perhaps there was one newspaper about Haivan who would actually give us the advertising for free. So there's a huge community aspect that can be leveraged, and we made use of that as well too. And then next slide, please. And these are all the different locations that we went to. We went to, you can see, it's hard to see, but the hospital and the health system itself exist in one point on the map. But we went out to this Hmong church in North Sacramento. We went to all the way down to El Grove as well. And we also went out to that large center there in South Sacramento, which is a very underserved area. And it's very Asian focused. And there are a lot of like different community centers that we went to and churches. There are temples out in the Art and Arcade area. And the only way we're able to, make it into these places was through the relationships we built with our community-based organizations and who would introduce us and allow us to come to their location and provide these free community screenings. Next slide, please. And so the impact, and this is a wall of text, and I will not be reading this to you, but I just wanted to place it here to emphasize that with our project, we did make a difference. And for one individual here, we made it on the individual level. He effectively, the stigma of hepatitis B was very real, and when it came out, he had concerns, but and I guess I wanted to emphasize the importance of what we're doing here through our MMRW project and through our project through the ScratchB and Hepatitis Foundation, is that we're making a difference in individual people's lives. He was screened, and through our infrastructure that we built, we were able to link them to care to our free clinic at the Paul Hall Asian Clinic and VN Cares. Next slide, please. And this is our hepatitis B linkage to care continuum. And you can see we were able to get individuals into screening and appropriate care. And then next slide, please. And we screened 72% of our patients over in the health system, and we were able to do screen 1,147 individuals from the community and get them into care. And on the left side, you can see that the reported cases in Sacramento County, it had increased since 2015. And so even with our project, we had an effect that is lasting into the community. So next slide, please. And this was our concluding dinner. This is our ScratchB dinner that thanked our partners and different individuals representing our communities were invited. And on the left was me, and the second is Tung. He's one of our collaborators who helped link us to the Burmese community, Dr. Bolas, Julie. We have 3 individuals from the clinics who came, and then Dr. Moon Chen. And acknowledgements, thank you for the work that, the grant that enabled us to do what we had to be able to do. And then next slide, and I think that should be the end of it.
Wonderful. Thanks so much, Duke, for sharing this amazing program with us. And then moving on to finally, we're going to hear from 2 joint programs of Northern New Jersey and New York City, and Lee Wong.
Great, thank you. I think it's been interesting just seeing everybody else's slides and hearing everybody's talks, because so many similarities with what we did, but there are also a lot of differences, and I find it very useful. And I feel like in my head, I'm thinking about ideas of how we can, some of the stuff the other programs did that would be interesting to try out too. So I really appreciate the chance to, for all of us to kind of collaborate and brainstorm. All right, so our program was the New York, New Jersey program. We did not have a cool acronym like Scratch, but ours is
trying to improve testing and screening and linkage to care also in hard-to-reach populations in this area. Next. So this is just a little background about the demographics. So New York City, we know, is very international. 38% of all the residents are foreign-born, and 13% of the population is actually Asian American. So you can see right there the definite need for screening and why New York City is a hotbed for Hep B. So New Jersey, not everybody knows, though, is also quite diverse. 21% of New Jersey's population is foreign-born, making it the third highest in the U.S. After New York and California. And New Jersey has the fourth largest API population in the U.S. And just a lot of it is very recent growth. So between 2000 and 2010, the Chinese population increased by 34%. And we continue to see that kind of growth amongst all the Asian groups in New Jersey. And this map kind of shows you where the Asians are located. The larger the circle, the more Asians in that area. And this has a little, shows you kind of the different ethnic groups within Asians. And you can see some of them, there's a lot of Filipinos towards the east side near New York City. In the north, we have a lot of Koreans in the Fort Lee area. And then Middlesex, a lot of South Asians and also Chinese. All right, next. So we had, because we had New York and New Jersey, so we had two sites. I'm going to go through each of them. Charles Lee Wong, as many of you know, has ongoing primary care-based screening and a really good comprehensive Hep B care in a federally qualified health center setting. And we at the St. Barnabas Medical Center, newer program, and so we were trying to see if we could adopt some of the Charles Lee Wong approaches to a different kind of setting, a community setting, community hospital setting in a suburban region. We are a primary care office that is employed and part of a larger hospital, but we don't have it. It's not an FQHC. So I'm going to go through some of the approaches that we took. Okay, next. All right, so first a little bit more information about Charles Lee Wong. So it's been around as an FQHC and a nonprofit since 1971. We achieved Level 3 medical home, and there are 4 clinical sites in Chinatown, across Chinatown. In Chinatown, there's 2 sites, and then 2 sites of Flushing as well. So it's got primary care specialists, social work, dental, mental health, a lot of staff to help, like social workers, a lot of nursing, a lot of education happening. The focus is on medically underserved and Asian Americans. Multiple languages are offered by the staff, and then there are additional departments which are helpful, such as research and evaluation, health education, and marketing. And just as a disclaimer, I used to work here, so sometimes I'll say we, even though I'm not currently there right now. All right, next. All right, so in the screening approach for Charles Lee Wong, at first, when I was there, we were still doing a lot of health fairs and getting out into the community. And then after a while, as we became more established with Hep B screening, a lot of it just became focused on really just making sure that all the patients that we saw for preventative care or being cared for at Charles Lee Wong were screened. And we, over time, at first we were using just surface antibody, but now it's standard to use all 3. So, and then there were some screening events also, but less so now. And then, like I mentioned, there's a good primary care-based Hep B care treatment program. Next. All right, so one of the helpful tools, which is kind of similar to what Sacramento did, is we made some EMR edit changes to help remind doctors and to quickly allow them to see if somebody had been screened before. So this is a Hep B page, and you can see there's a place for a registry. So if somebody's found to have Hep B, you would click on the registry button, and when you do that, it automatically pops up on their on the top screen. So right away, some of the top conditions, you know, whenever you see the patient, if they have diabetes or hypertension, and also Hep B. And then here you can see where it's already auto-populated if they already had the test done. So if you're seeing somebody and you notice that that right next to surface antigen, there's no result that's populated, then you know that person needs to be screened. All right, next. All right, so now we're going to move to New Jersey. And so our model is different because we don't have a site with that's dedicated to Asians with all the the primary and the multidisciplinary care all focused for Asians, but kind of very similar to what Sacramento was. Oh no, actually, Karen, you were presenting this about how you have a community organization, you use a community-based organization to really help reach into the community in a way that like a mainstream hospital or other healthcare provider cannot. So St. Barnabas Medical Center is a hospital that we're at. They have obviously extensive resources for medical care, really good service lines, high quality medical care, a department for community outreach and marketing, but not necessarily the know-how to get into the Asian population. So we see ourselves as kind of a bridge to reach into the Asian community by partnering with community groups, having access to ethnic media, knowing how to really reach the Asians, and just even the ads look different in the Asian newspapers, and then that patient navigation really to help people navigate a very complicated medical system in the U.S. And then obviously the language and the cultural the aspects are really important too, and our medical practice has bilingual staff. All right, next. So we've been around since 2013. We have several primary care doctors. We have some specialists that rotate through, like every other week. We have a cardiologist, GI, psychologist. We do navigation. And a lot of what we do is outreach, just to let people know we're even here. We found that in our community, there are a lot of people who aren't accessing primary care at all. And like Karen said, there's just a lot of barriers that keep people from seeing care. So a lot of what we have to do with those disparities is kind of reach people where they're at. All right, next. So these are just some snapshots of some of the events that we've done. So we paint places of worship, Buddhist temples, also churches. Language schools are a really popular place because people are there on the weekends with their kids. And Chinese New Year events are some of the examples of places we've gone. Next. All right, and one of the things we try to do is also try to train another practice. So we have we are a teaching hospital, and we have a number of residencies, and one of the residencies was actually in our building. So we thought, let's see if we can train some of these other primary care doctors, especially residents, because this is something they'll hopefully take with them wherever they end up. So there are 5 attending, 30 residents at this clinic. We started doing this in 2016. It was a little harder than we thought. We didn't have the ability it required like very individual collaboration with attendings, but also individual chart review of patients. And we were able to set alerts and reminders to doctors, but doctors had to actually still order the tests and know the right test. So we actually even tried to educate them by telling them your patient's at risk because they're from wherever, or if it was something else, like because they're on dialysis or something, we would actually tell them, and then we would tell them which test to order. So, and then the barrier sometimes was survey and consent, and we found this to be labor intensive, but it was something that they eventually adopted, and so that they started putting it into their templates for physical exams. Okay, next. So this is the screening coupon Erin was alluding to, and so what we were hoping is to really bypass the barrier of even seeing a doctor or having the doctor order it. And we had this is like a 5x7 card, like a postcard type material. And so we felt like if patients feel like they're at risk, and we told them if you're from one of these countries or your parents you're at risk, they should be able to show up and get tested. And so we gave this out at the health fairs. We drop it off at different offices. It could also be printed out on our website so that, if we didn't have extra copies, they could still download it. And next. And then we basically, this shows you all the sites where we could do the testing. So all the lab sites that the hospital had. The hospital has a number of outpatient labs. This fulfilled kind of the legal requirement for lab requisition. It had my name. Patients had to write their own name, and that we handled the billing kind of behind the scenes. Okay, next. So, and then we did a lot of campaigns in the print and online ethnic media. So some of it, not everybody has a kid that goes to Chinese school or goes to place of worship. So this is kind of a wider reach than our health fairs. And we would take ads out, and then in return, the newspaper would actually do a story that we could write up about hepatitis B. So that was a way of educating the public too. And we also tried this thing where we had a survey to try to find out people's knowledge of Hep B, and we asked people to send it in, and they would be submitted for drawing. So that was helpful for us to kind of do a community needs assessment on Hep B knowledge. Okay, next. So this is an online campaign, and this was helpful because CDC and Cynthia Jorgensen's team had just developed their No More Hepatitis PSAs, which were really great, and they worked through this group, IW, which has had a lot of experience in doing media campaigns for the Asian population. I think they did one for McDonald's. And so we worked with them using the CDC ad, but then personalizing it with our logo, and these ads would actually, if clicked on, they would link to our Liver Be Well website, and people could fill out a form to get tested. And so we did a number of ad buys, basically by targeting certain zip codes, age, and ethnicity. And so somebody's on the internet, it would if they use some of these popular Chinese websites like video streaming, shopping, or newspapers, they would see this ad. So we got a large number of hits with this. We didn't necessarily get increased screening, which was kind of disappointing, but we know that it did have a really, really wide reach. Okay, next. So our combined screening results, this is between New York and New Jersey, our surface antigen positive rate was 7.5%. About 50 were immune. 50% of the immune were from previous infection, and about a third needed vaccine. All right, next. So in here, this kind of looks at the demographic differences between the population screened in New York and New Jersey. So a little bit older New Jersey, a little bit more female. Maybe that's because we did more health fairs, and that seems to be the reach that you have there. The birthplaces are a little bit different. New York City was largely Chinese, from China. We had more U.S. born Asians, I guess, and then we had more Taiwan, people born in Taiwan. So one of the other differences is more a lower number of uninsured people in New Jersey, and of those who had insurance, a larger percentage of people who had private insurance. Okay, next. So this is something we wanted to kind of ascertain is like of the people who had insurance, okay, which is 75%, this is in New Jersey, we asked them if they had a PCP, and 65% said they did. But that means there's also a big gap. There are a lot of people who have insurance but don't necessarily have a PCP. And then for those who do have a PCP, we asked them, have you been screened for Hep B? You know, obviously this is their self-report, but still it shows a pretty big gap. So only 30%, said that they knew that they had been screened for Hep B. So even people who are insured, there's still gaps for Hep B screening. Okay, thanks. Next. All right, so this just kind of shows similar to the one that was shown for Scratch. This is all of our community site events, and then with the red dots, that geomap is kind of showing you the attendees. So it kind of shows that we had people. What we find is that when you offer stuff in languages, that people do come from much further than potentially what the hospitals used to in terms of the service areas. So you could see that we have people coming out from Pennsylvania and even the Maryland area for screening. All right, next. All right, so Aaron talked a little bit about this. This is our household contact screening information. So household contacts I think this project really showed that are a really high-risk group. So in this group, I just showed you that our main screening group was 7% Hep B positive. For the household contacts, it was 18%. And there's still room for vaccinating these patients too. So still a third of these patients are non-immune and are really high risk. So these are people you want to target for vaccine. And we were really appreciative that the CDC immunization department was able to provide us or help us fund some of these vaccines for these patients. So that was really, really helpful. All right, next. So the other thing we found that was really interesting, this is out of our total screened population in New Jersey, is that being foreign-born definitely meant that you had a higher rate of being exposed. So either current infection, previous infection, or isolated core. This is anybody who tested core positive. And when you look at it by age groups, it definitely goes up by age. So if you're foreign-born and older, there's a really good chance that you've been exposed to Hep B, either currently or in the past. And what we realize now, there's just a higher rate, but there's a lot of interest in reactivation of Hep B because we know it's a real issue, and as you get older and are more likely to develop cancer or need immunosuppressive therapy, this is something, as we've been counseling patients, that we find is really important to tell patients because not all oncologists and not all physicians are aware enough to screen patients. And we've seen a number of tragedies happen in our area of Asian patients who were not screened for Hep B prior to going to chemotherapy and had a fulminant liver failure. So this was, even though the core wasn't a required test for the CDC grant, it really allowed us to identify a lot of these patients and then counsel them appropriately. Next. So lessons learned. I'm not going to go too much because I know we're running low on time. But I think a lot of it is similar to what everybody else has said. This grant was really important for us to be able to go a lot further with reaching out to the community than we could have on our own. We learned a lot about how the suburban population can look very different from an urban Asian profile, but still have a lot of gaps, even if they're more insured. And also we had started screening Africans and Caribbean too, and there's big gaps in those populations too. So we do hope that this provides some data, and maybe CDC will be able to use some of this data to help, fund additional projects, similar to what we were doing. So thank you very much. And then my last slide is acknowledgments. So thanks to everybody who contributed to this.
Thank you. All right. So if you could mute your line if you're not presenting, and we can reduce the echo. Thank you. So we'll now begin the question and answer portion of our webinar. And as a reminder, if you would like to ask a question to any of our presenters, please feel free to send them via the question box, and then I will read them out. And then we do have a few questions that were submitted during the presentation. And I wanted to follow up on the household contacts that Erin mentioned. There were successes in the program overall, and Sue had talked briefly about it, but I was wondering if you could share a little bit more about reaching those household contacts through the primary program, and what were the best practices? Was it through patient navigation, or if there were any challenges that you wanted to share? I don't know, Sue or Erin, you wanted to take that?
I'll let Sue take it since she was more involved in the mechanics of that.
Yeah, so this was, we found that it was really, really helpful because for our navigator to be involved with this process, because she got to know the patients pretty well, the patients that started coming in here who are already found to have Hep B. And so she would call them or meet them in the practice and say, hey, you need to bring your whole family in to get tested. And I think that personal contact just kind of, and then she would educate them, obviously, would be helpful to get them in. And then it would really help us to track it, because it would be hard, I think, if someone just showed up for testing and you didn't realize that they were a household contact. So I know we've been brainstorming about ways to do it. When I was at Charles Lee Wong, the health department sent out letters to pregnant women who were positive and had letters that had unique codes on them to offer free testing for the household contacts. And if they came to Charles Lee Wong, we would have that ID number, and then we would be able to collect all that data and then provide it to the health department so they could actually connect the household contacts to the patients. But it is, I think, involves extra layer of tracking.
Great, thank you. Our next question is, Paul is still on. You had mentioned earlier about recent grants that you provided related to state elimination programs, providing technical assistance. I believe it was through ASTO. If you are able to or allowed to, if you could talk a little bit more about that, what that looks like, and which states that you'll be focusing on.
Yeah, this is Paul. Paul Weidel, Acting Director of DVH. I can't talk with too much specifics. We're still finalizing the work plan with them. But basically, so again, just to reiterate what I said, so we've funded the Association for State and Territorial Health Officers to assist us to help develop elimination plans for hepatitis B and hepatitis C with states. So we're still finalizing the work plan, and there would be like a, I guess like an RFA or a solicitation that would go out from ASTO to the states to apply to be part of that. But so I don't want to say too many specifics, but basically the concept is we know some states are already moving forward, already have developed plans, and so we would want ASTO to help them move that forward. And then for other states that are thinking about it but really haven't started, anything, put anything together to try to help them put things together based on what we're learning in other places, to help each state develop a elimination plan for hepatitis B and hepatitis C. So that's the work idea. Again, we're finalizing the work plan. So the project has been announced in general that we funded it, but we're still waiting to finalize our work plan, and ASTA will then move forward after that. So no states have not been selected yet.
Got it. Okay. Thanks for sharing. All right, and we are running short on time, but I did want to make sure to ask this one question. Maybe it's a two-parter. We do have an international audience as well joining us, and either Paul or Aaron, does CDC have a working relationship with community organizations in Africa? And then just as a follow-up to that, there was a question related to vaccination offered to adults, and I think they're speaking more about the availability of Hep B vaccination for adults in other countries, even though this program was able to offer vaccines to adults in the U.S. If you could talk about vaccine availability overseas, because right now the understanding is that the birth dose is emphasized. Aaron or Paul, did you?
So at CDC, we focus primarily on domestic policies and implementation projects and partnerships, especially in our division. There is a global immunization division at CDC that works on global vaccination strategies. They would probably be best to talk about availability of hepatitis B vaccine and specific partnerships that they have. We do have a few hepatitis B care and treatment programs that we provide technical assistance to in Africa, and we have partnerships with local groups there. But it would be hard for me to answer a general CDC partnerships with African community organizations or availability of hepatitis B vaccine globally. Thanks.
Thank you. I think that's helpful. All right, so we are running a little bit over time, and I appreciate everyone who has stayed on. We are going to go ahead and conclude our webinar, and I wanted to thank everyone for that really rich discussion. I think that you hit on a variety of strategies that hopefully we can replicate as best practice, especially all the three programs showed the success of EMR prompts. And I think that is really key to increasing screening across the board in the communities that are hardest to reach. Really hope that we're able to share your programs beyond this webinar as well. So if there were any questions that we were unable to answer today, I'll be sure to follow up with you directly. And if we didn't have time to take your questions, please don't hesitate to contact us, and we're happy to pass that on to our presenters. As you exit the webinar, please be sure to fill out a survey. Tell us about your experience on the webinar and any suggestions you have for other webinar topics you'd like to see featured by Hep United. And finally, I wanted to thank you to our presenters for joining us today. Thank you for your time and your expertise, and really appreciate you. So I will be following up with an email with a recording as well as a copy of the presentations from today with the permission of our presenters. So I hope you all have a really great day.